Is radiation protection story real?
Yes.
And let me tell you why it concerns me. I go a lot to out of the US labs, and I see these young generation guys doing CTOs, 2 hours of procedure, doing endovascular procedure with the X-ray tube.
Yep.
And I always say that this is like the atomic bomb. It takes 30 years for radiation to catch up on humans, and we may at some point start actually seeing potential side effects in our own operators, in our own population.
Right.
I mean, so tell me what you think about
Yeah, no, it's worrisome, especially one as we get into more complex procedures and we're sitting there under the radiation. There are some basic things that we know we can do. You want to decrease your fluoro time as much as possible in every procedure. You want to try to maximize or minimize the source to image distance as you go. You also want to do things like collimate as much as possible, do an angiogram, and then magnify it. But there's some really cool stuff that's out there right now.
But let me ask you this, before we go there, because this is the thing that actually, bothers me a little bit. Do you think people are aware of this?
I think part of the conflict as physicians will allow ourselves to even be exposed to something harmful to help someone out. But it's the real deal. I mean, there are a couple of Canadian interventional cardiologists that have developed left-sided brain tumors. Females, interventional cardiologists, more left-sided breast cancer than right-sided breast cancer. We're wearing thyroid, lead, so that when we look down and we look up, we're increasing the lordotic curvature of our cervical spine. Wearing 30, 40 pounds of lead is a problem as we do these more difficult procedures. I'm involved in some chronic limb ischemia. I mean, you are right there. Sometimes you actually see your arm go under and through the fluoro. So it's important. It's something we've got to pay attention to.
So tell me the categories of technology innovation.
There's some really interesting technologies where the eye follows the physician's eye. So what happens is you get automated collimation on the side. That's very cool.
That was actually, they presented a Shark Tank.
Yeah, that was control rad. Exactly, really cool. And then of course there are kind of the drapes, zero gravity, the protege system, which is diagnostic imaging. So, those things are almost walk-in, zero gravity that drops down. They're making it nice so that you can get radial access easy. You can push a magnet and then detach it. But simple things like, LAO view, AP cranial view, just keep away from things like that. We're not going to get away from it until we get to robotics.
So one thing is that is important is not only about the physician, all right, but also about the personnel and also, the patient. So, I mean, I guess that some of these tools will protect more certain people than actually other people. A big concern to me is the nurses. I mean, especially if you've seen in acute procedures, nurses are trying to actually do things and you have the tube. Is a little bit actually is scary. But let me ask you this question because I really think it's important. And is the brutality of the financial healthcare system. I'm an administrator. You come to me and say, hey, Dr. Granada, I'm concerned about radiation and I want you to buy me the zero gravity system because I don't want to get radiation. It's going to cost $500,000 to buy X system. And I'm going to say, what is in it for me? What is actually the business model for hospitals and systems to adopt radiation protection technologies? Because to be perfectly honest, some of the systems they say, you know what, I'm paying you well. Just work is an occupational hazard. As the guy that is, cleaning windows in New York, and look, you have insurance. And so how are we going to be able to create this ecosystem in which the value creation of these technologies can really give something back to the healthcare system? It's productivity, it's protecting productivity of physicians. How do you see this working?
Boy, I admire your brutal honesty. And it's really true. It's hard to go to an administrator and say you have a return on investment for this $300,000 or half a $500,000 piece of equipment.
Especially in places that you have 10 cath labs.
No question. Then how do you pick which cath lab and you multiply it out? I think it is a huge recruitment and retention tool, number one. I think right now in cardiology, we're involved in peripheral vascular disease, structural heart disease. We're going to be involved, in my opinion, in stroke. We've got STEMI. There are so many divergent areas that there's going to be a shortage of interventional cardiologists. There's actually a prediction by the U.S. Workforce by 2030, we're going to be down about 50,000 specialists.
Unbelievable.
So a very important recruitment tool, retention tool. We need more women in medicine. To have a woman constantly exposed to radiation is a problem. You can increase.
Which for them specifically is extremely important, especially the ones that are in the age to have kids and everything is extremely important.
Absolutely.
You've been doing amazing things in India. I mean, it's fascinating to actually think that you can treat patients remotely.
Yeah.
While you are, watching the case and you're operating the system. Maybe a few words about robotics and telemanipulation.
Yeah, I really think it's unbelievable, and I think it's going to be transformational. So Dr. Tejas Patel, we just presented this in the Lancet and published it in the Lancet, did several stent procedures from more than 100 miles away from his office. So he was literally sitting at his computer with the cockpit, moving the wire, moving the balloon, placing the stent, etc., from a place 100 miles away.
It's mind-blogging.
The global impact, though, Juan, is huge. So if you look at our interventional primary angioplasty and MI, the last decade only 50% were able to get primary angioplasty. The other, about 40 to 50% got lytic therapy. Why? They can't be treated within 60 to 90 minutes, or whether there's not enough hospitals. So this is going to be huge for global health.
That's what I call social-based innovation, and it's actually an amazing opportunity to actually achieve that. So, look, this is the type of discussions we have in the hallways of
this is why we have
academic
meetings,
and it's been a pleasure to have you here.
Thanks.
And thank you again for
always a pleasure.
coming to be a part of it.
All right, you got it. Thanks very much.